Okay, so this is kind of a synopsis of what we might have done if we'd had our Lunch and Learn live today. So what we want to do is just help to give you some pointers on how to finish out the semester strong, uh, to help you remember that you already know a lot of this information. Quite a bit of what I'm seeing, and when I do test reviews, is people are making mistakes on simple stuff. For example, if a question is talking about symptoms of, say, hemorrhage, they may pick that there's a low blood pressure, but then they go with bradycardia. And we know typically with perfusion issues, hypotension is accompanied by tachycardia. So simple mistakes like that is one of the things that I'm seeing as just basic stuff that y'all know. And we need to reinforce that you need to remember those things. I'm going to show you a few different ways to look at concept maps and how they could work for you, or how you can make what's worked for you in the past work from the concept map platform, but still be something that makes sense to you as you're studying. And we'll just do a few practice questions using a methodology that I've found to be pretty helpful for students. I'm going to share my screen, and we're going to look at the pulling it all together. All right, so as we go to a slideshow version here. All right, so now y'all are down to the end. I mean, y'all are getting ready to graduate. Now's the time to really focus in on getting your mind straight on what's really important, and that is finishing school successfully. It's neat, the other things you can put aside, now's the time to do it, so you can focus on getting through this class and getting on to nursing 2350 and graduating. So it is going to be a tough few weeks. Y'all are getting ready to be nurses who have a license to, and you will have patients' lives in your hands. Now it's time to critically think, put all the pieces together, and see the big picture on what is the safest answers on the test questions, but then what is safe for you to do in practice. We're teaching to be a practicing safe nurse, not just to pass an exam. So you have to pull together what you knew before, pull it forward now, and put it to use and applying it onto the exams. Okay, so here we go. So first of all, this is just an example of a concept map that I pulled off of your Unit 3 content that I think Mr. Young may have used when he talked about acute kidney injury. And so if this type of concept map works for you and you can see the connections, so you've got your what's wrong with the patient, and these are the types, and then there's phases within those types, and then as I know, okay, I'm taking care of a patient with these things going on, so these are the labs that I'm going to see on my lab reports, which will lead to these assessment findings or your manifestations of the disease, which I need to recognize early complications by doing these assessments to then pick up on this is what's going on with my patient. So I know they're either improving or they're going down the hill and I need to do something about it. What I'm doing to maintain their perfusion, especially if they are in, like, say, that diuretic phase where they are losing tons and tons of fluid. How am I going to maintain good kidney perfusion? Some of this is going to relate back to why are they having acute kidney injury in the first place? I mean, did they have some type of accident where they had a large hemorrhage? And so there was lack of blood supply to the kidneys for a while that then caused that renal failure to begin. So some of it's going to depend on why do they have this problem in the first place. And so as I'm working on maintaining perfusion, I know there may be medications that I have to give in conjunction with maintaining that perfusion, right? And those medications then can also lead into what the proper nutrition is for these patients in relation to what are their manifestations in their labs that I'm seeing over here, what nutritional things am I going to do related to their potassium, their sodium, their other electrolytes, their protein. We know red blood cell production comes from the erythropoietin that the kidneys produce. So do I need more iron and things like that within their nutrition? Do they need TPN? What are their other labs showing on their CMP? Are we seeing low albumin and things like that? Or because they have kidney injury, so maybe they're spilling a lot of protein into their urine. So all those things come into play. And then hemodialysis is one of the main treatments we know we use if we're not able to get them with some functioning kidneys pretty quickly. We know hemodialysis is a way to at least temporarily, if not for the rest of their life, be how they're going to maintain proper kidney function to get rid of fluids and toxins. So this is just an example of the concept map that he used in class. So if that works for you, that's awesome. If you don't think that this makes sense to you visually, you can, if you're an outline person, you like a linear look at stuff, I'm going to show you how to make it into an outline with the exact same information. It just looks different. It may be something you're used to doing from PowerPoints, which are essentially an outline. This is an outline. It just requires you to fill in the blanks. So our expectation, as always has been the case, is to read your content before you come to class. Then I suggest you make some notes as you read the content of questions that you might have, things that are unclear that you would want to, if it's not answered by the lecturer during class, that you have those ready so you can ask those questions during class or even after class or on the discussion boards. Be sure that you understand the objectives for the unit. So look in your syllabus. What are the objectives for that unit? Those are things that should be being covered in class because that is your blueprint for the exam, is the unit objectives. So make sure that you've read about each of those unit objectives. And if you don't have a good handle on them, then you need to come to your mentor or ask questions on the discussion board or come to one of us and see if you can clarify to make sure you understand each objective. And then I would want you to, in class, obviously you're going to complete what you can of the concept map. If your instructor's okay with you recording lecture, then by all means do your audio recording. And then go back as soon as you can after class. You want to fill in your notes. So if you missed some of this during the lecture, don't freak out. Pay attention to what they're saying. Make some little notes to help guide you to say, okay, I need to check chart blah, blah, blah on page 861 after class. Make yourself notes so you can go back and add that information later so you can still listen to what's being said in class, because that's where they're making the connection from content theory to practice, which is what all the questions are about at this level, is application level and above. So getting ready for the NCLEX, the questions get harder. And so this is how we have to make those connections of drawing the dots, connecting those dots to make the big picture of what we need to know for safe care of the patient. After class, then that's when you're going to fill in all the details of what you might have missed. Look through your IGGY book and see, maybe just highlight a few things during class that the instructor really pointed out as being very important. I also highly recommend after class, take your ATI Med-Surg book. You have that book available. Look up the concept that was talked about in class that day. If it was acute kidney injury or renal failure, read through that Cliff Notes version of renal failure, and it might point out a few things that you didn't catch in class that are really important. So those nursing alerts in those books are really, really helpful. And it's another way to just review to make sure you didn't miss something vitally important. And then finally, I would recommend the ATI pharmacology book. Look up the drugs that are talked about in class, that are listed in your syllabus, through your ATI Pharm book, and it'll give you a good little synopsis of that drug. What are the big red flag nursing things I got to know about that drug? What labs go with that drug? What teaching goes with that drug? What is a big side effect or adverse reaction I have to assess for the patient that's taking that particular medication? And then use the thin thinking, which is a mechanism I want to talk to you about next, about test taking. To kind of help you pull your thoughts together as you're on the test. We've moved you up to 75 questions, so we're getting you ready for NCLEX. You're getting ready to run a marathon. So more questions you take and get used to it, the easier it'll be on your NCLEX. If you're getting the maximum number of questions, we don't want you to have exhaustion during that test. So more questions help you, I think, not only in gaining stamina, but the more questions you have, the better chance you have of getting more right, in my opinion. You get more time per question, so the time is increased from what it was earlier when you only had 65 questions. So keep that in mind. You can set up ATI practice quizzes yourself and you can design how many questions you want on them, what content you want it pulled from, and then sit yourself down and give yourself a practice test session like it was the real deal. So you can be practicing those mechanisms as you're getting ready to finish out course this semester, and then 2350 is going to be all ATI testing, and then that's all getting you ready for NCLEX. And it is a tried and true method. Believe it or not, our NCLEX pass rate is 90% right now from the last 2 classes. And so we feel that you're getting the information that you need. We understand there's frustration just because people are stressed and tired, and we want you to know that we are all here for you. Every single one of us want you to be successful. It doesn't help us if you're not successful. The goal is that you're going to graduate and be a registered nurse. So believe us when we tell you we're trying to give you everything that you need to be successful. It does require you to do some of the work yourself, but if there's stuff you don't understand, that's why you have a mentor. So come to us. I'm doing this now because I've had some people request it. And I just felt like now's a good time to just give you that reassurance that you already know this information. We're just helping you to reconfirm that and reconfirm that you actually know quite a bit, or you would not be in this course. You would not have made it this far to not know what you're doing at this point. So here we go. Outline format. So here's where I just took what Mr. Young had in his concept map and put it to an outline. So if you like outlines, if you like PowerPoints, which like I said is an outline, you can take the concept map and make it an outline. So an outline would be you'd have risk factors of acute kidney injury or whatever the concept is that you're looking at that day. List what those are. Think about a question that might be a teaching question, prevention or early recognition, things that you can do as the nurse where they may say, well, how would you educate your patient with diabetes mellitus to help them prevent renal failure? And so that might be a question that lists back to that's a risk factor. So how you would teach that person to reduce morbidity and mortality. So morbidity is further injury, mortality is death. So then acute kidney injury is your concept here, your disorder. So you'd want a brief definition of what that is. Then he listed it as having 4 phases. So, well, I guess it's 3 phases with 4 phases within the intrarenal till they move to post-renal. I don't claim kidney as my expertise. I just took this as an example. This is not meant to be a review for Unit 3's test. It's just another way of looking at study method. So here you can, with each of these, you'd want to give the main characteristics of what the nurse needs to know about these phases and these interphases within the intrarenal to the post-renal stage of this disease process. So what do I need to know as a nurse, and what's going to help me to recognize my patient is having complications? The rest of the outline will include your nursing process that goes with that. So what are the expected assessment findings? Subjective, what's the patient telling you? That's subjective. Objective is the actual stuff you can measure, like their vital signs. So what are those things that you think you might see or hear or assess or be told that go along with a patient that's having acute renal failure? So list those out. Think about what labs you would see. BU and creatinine, we know we're focusing on the renal. So what are those going to look like in this type of patient? How is your CBC going to look? What are your CMP panels going to look like? What's their potassium going to look like? Their albumin. Focus on the renal assessment piece. So we know we're worried about their elimination. That's our overall concept we're looking at, is elimination and perfusion, possibly depending on why they have this acute renal failure that's going on. INOs, daily weights, which we know are more accurate than INOs, correct? I taught y'all that back in 1410. So weighing the patient daily, make sure that you're measuring how much urine they're putting out. And then based on these plans and interventions, then you're going to have things that go along with the assessments that you found. So the nutrition needs of the patient, what are they doing for the protein? What do they need for iron? What about their fluid needs? What other nutrition things might they need along with their labs? So their labs and their findings in the assessments, what's going to drive the nutrition orders. What's their elimination looking like? You know, are they putting out urine, putting out too much urine? Do they need dialysis? If they're on dialysis, what implications does that mean for you as the nurse? What are safety risks for hemodialysis patients? So those are the things I would add into my notes as I go along to make this outline have the details that I need to know about a patient in acute kidney injury. What medications were discussed in relation to treating this patient. Make sure you've checked your ATI pharmacology book, that you didn't miss anything based on what Mr. Young taught you and what's in your IGI, and then what you find in your ATI book to help you know about those red alert needs. And then what evaluations are you going to find that show the patient's getting better? You know, if you are worried because they have oliguria, and then we're treating them, and then they start to show a normal urine output, obviously that's the evaluation that shows that they're making progress. What if things aren't working? So here's where you're looking for signs and symptoms that show they're at an increased risk of some more severe injury or dying from this. So what are those red flag assessments that you have to be watching for to see if we need to do more? What if they have a super high potassium level? You know, their potassium 6.7. I mean, then we're thinking, okay, they're going to go into a cardiac arrhythmia and they're going to die. So what are the medications that we're going to have to give to help pull that potassium off to help prevent a cardiac arrest in this patient? So those are things you could do in an outline format. One other idea is using your clinical judgment tool. We use it in clinical for a reason. You may feel like it's a waste of your time, but it should be where you're getting all these disorders over time. Hopefully you've seen many patients with some of the actual things we're talking about in class from the beginning of clinical till now. You're almost at the end. So why are they there? And what are the top 3 things that we are worried about for a patient with that particular diagnosis? And then all this and the patho, the little bit of brief patho behind it, is what's going to drive everything else on here. So if your priority problem is that they have fluid volume overload because they have acute renal failure, then what assessments are going to go with that? Obviously, you're going to look at vital signs. You're going to look at their blood pressure. You're going to look at their INOs and daily weights. You're going to look at their labs, which kind of come down here as we're thinking about which labs go with that. What are the main risk factors that they have here? I mean, they could develop pulmonary edema. That could be a potential complication, right? So respiratory problems, risk factors if they're diabetic, how's their diabetes been controlled? You know, looking at why they have this problem in the first place. There'll be psychosocial concerns related to this. So what are those? We know in Maslow's those aren't the highest, but they're also, they have to be addressed, especially if your patient is getting to be to the suicidal ideation piece of that then becomes a safety concern. What's the teaching that goes with this? And that's still back to safety related to the patient and the family. What are we teaching them about it? What interventions? So our assessments over here, which are driven from our problems, or what drives our interventions and the things that we know we're doing to help take care of that patient. Maybe administration of the ordered medications such as diuretics to help pull off some of the fluid. And maybe that we're being very cognizant of their skin because they came in from the nursing home with skin breakdown, and maybe they have sepsis from a urinary tract infection, and that's led to acute renal impairment, and their kidneys quit working because of that. So there's multiple things you could put here. It's all driven by what the problems are, what the assessment findings are. So these are all connected. And then what complications from the procedures might you see? So if someone gets hemodialysis, what are the risk factors there? You could definitely throw off their electrolyte imbalance and cause imbalances that could lead to cardiac arrhythmias. So think about what are the killer things here, because we want you to be able to pick out early what is a killer assessment that I see that I have to do something about right now, or my patient could die. That's what you're looking for. And then what would the report look like? So we've been doing that in clinical. Here's one that I just did just for fun. And back when I was teaching pancreatitis, and this was my way of putting pancreatitis into a clinical judgment plan. So I know you've had pancreatitis in class. And so I'm this is just how I would use it to study for me, because this makes sense to me. If the other concept maps don't work for you, maybe the clinical judgment plan would. It helps me to pull it all together. I'm also a circle drawer, so I may draw circles and say, you know, in the middle I've got pancreatitis, and then I know it's got a endocrine issue. I know it's got a GI issue. So it has exocrine, endocrine things that it does. It helps with, you know, digestion, and it helps with regulation of blood glucose levels. And so from there, if it's not operating normally, here's all the assessments I'm going to find when their insulin, their glucagon aren't working right. Here's all the problems I'm going to find over here if it's a GI problem and their digestion is messed up because maybe there's a bile duct clogged from a stone from gallstones that's causing all the pancreatic juices that normally go through the bile duct and into the stomach to help with digestion. Maybe now that's blocked off, and so all those digestive enzymes are backed up into the pancreas and it's basically digesting itself. And so I know that necrosis is the biggest risk for these patients because that can lead to shock, septic shock, which is fatal if not treated quickly. That can lead to hemorrhage, which is fatal really quickly. If your pancreas begins to hemorrhage, you will die fast. And so it can lead to renal failure and DIC, which is also deadly. So there's lots of really severe things there that are driving what my assessment needs are, what my interventions are, what my labs are going to be, what are the patient teachings that go along with that, what are my problems I'm worried about. So you can use this, make a circle, make an outline. It doesn't matter. It's what works for you to make it make sense to you. Here's where I did just my drugs related to pancreatitis when I taught this content. So these are some of the common drugs you'd see that they would be on. So as a student, I'd also need to know, well, what I need to know about these drugs, the main things, the common side effects, the life-threatening things. With morphine, too much. We know the respiratory effects can happen. They might stop breathing fast enough. So then I need to know, what is the alternative for morphine? What is my what am I going to give to reverse it, the reversal agent? So I need to know about Narcan or naloxone. They need fluid replacement, including the electrolytes. They may need protonics. They may need something for antiemetics instead of Dansitron. So what are the big things I need to know about safety for that? You can't give it too fast. So those are the things to pick up on for safe use of those medications for that patient. Another thing some people like to use is just the 3 critical points. So what is the main client need related to whatever disease process I'm looking at? So if I'm thinking about kidney failure, the main client need is that they're going to have fluid volume excess, right? Unless they're in that polyuric phase, most likely they're going to be retaining too much fluids. And so I'm worried about fluid buildup, which can lead to other problems down here related to respiratory. They can go into pulmonary edema. I'm worried about their electrolytes. They can have super high potassium because it's not being eliminated. So I'm worried about cardiac arrhythmias. They can have protein issues. So maybe they're spilling what urine they're making is spilling protein out. So they may have really low albumin, which causes even more retention of fluids. So you're looking at a lot of issues here. And then, you know, your overview of the content that you know about that problem. And what are the 3 main things that you're going to be worried about in taking care of a patient with acute kidney injury? You know, I'm worried about what is their output really doing? What's the level of their kidney function that day related to their INO? What was their weight today compared to yesterday? What vital signs am I seeing? What are the labs showing? So I can have at least an idea of where they stand today while I'm taking care of that patient. Are they showing other symptoms that maybe cardiac arrhythmias that tell me their electrolytes are off by a high enough level that I need to talk to the doctor about what we can do about their potassium being way above the normal range that's causing them to have these cardiac dysrhythmias? Maybe the third point would be related to their red blood cells are extremely low because they're not making erythropoietin anymore because their kidneys are shutting down, and that's where that hormone comes from. And so maybe the patient needs a blood transfusion because they are so low in their hemoglobin hematocrit because of lack of red blood cells. Their perfusion is now a problem. They're not getting oxygen to their vital organs. So that's the way you can use this, just pull it all together in one spot. So as we're thinking about thin thinking, so thin is the acronym, and I'm going to talk about that. It's the top three. It's help quickly, identify risk to safety, and nursing process. So this is stuff to apply to your test. And we'll go through each of these. The top three, think about what are the main three things that you think this question is really wanting you to know. And we're talking about a new graduate nurse in the perfect NCLEX hospital environment, which means don't think about what you do at your normal job. If you work as a tech or an LPN or a paramedic or whatever healthcare place you're in, or what you're even seeing in clinical. NCLEX in our testing environment is that you have everything you need, including staff, and you're new. So what do you need to know? What's the question I want you to be able to do? So with that, what is it asking? So think about prioritization power and what's the top three needs that you see, and it's going to be usually based off these 6 things. So the first one, Maslow. So we're all familiar with that. So we know physiological needs come first. And so air, that's where we get into our oxygenation problems. Nutrition, they need their volume of their fluid volume to be at a normal level. So excess or not enough, but they've got problems. And then of course they need to sleep, they need a place to live, they need clothing. That's basic physiological needs. And safety, we get up here with their health. And then there's other things here. Obviously they're going to come into play as we're thinking about longer term care for them if they have chronic health needs. And then we move on up the chain. Most of our questions are going to be in these bottom 2 because we're looking for safety right at the beginning of the graduate level nurse entering practice. So here's just a practice question for you to look at. As you look at this question, think, and these are not based on getting ready for Unit 3. This is just general test taking strategies. So this is a client that has schizophrenia. So you have to think back, what is schizophrenia? And medications we used to treat it. So you got haloperidol, which you know is a first generation antipsychotic. You got benztropine, which you know is an anticholinergic, because we know haloperidol affects acetylcholine levels. So that's why your anticholinergic comes into play as a PRN drug. And they're on zolpidem, which I have trouble saying, but that's a sleeping pill. So 10 milligrams of that. So which client behavior, which is here, really what I want to know is we have a client behavior that's happening that causes us to give our PRN drug. So think about which behavior is going to say benztropine is going to help because haloperidol is causing a problem. So you have to know what this can cause, what this can fix. Okay. The zolpidem is just a distractor that's in there. It has nothing to do with the question. So tactile hallucinations. So here I'm thinking, is that normal for schizophrenia? Schizophrenia patients can have tactile hallucinations, right? That's normal. Halo is being given for that, but I'm not going to give something to counteract that. If they're having that, means they don't have enough Haldol, right? Tardive dyskinesia, we know that is a significant adverse effect of haloperidol that does not have an antidote other than to stop the haloperidol. Benztropine will not fix tardive dyskinesia. So that is a acute alert, but it does not answer the question. Restlessness and muscle rigidity, we know that is a sign of Parkinsonism or EPS symptoms that comes with haloperidol. That is often caused in relation to the acetylcholine. And if they're having that, then they may need benztropine, which helps counteract that side effect. Reports of disturbing voices, that is also a symptom of schizophrenia. So I can mark this one out and this one out. And then if I'm thinking between these two, I know this one can't be fixed by any medication other than stopping the one that's causing it. But I know this is a side effect that can be fixed with benztropine. If I'm thinking this also is what my patients with Parkinson's disease have, what do I give Parkinson's patients? Anticholinergics. So that's how you think through that question to help get back to answering your original thing in Maslow. This is a health and safety concern related to pharmacology. All right, because if this continues, they can end up having really severe muscle rigidity. It can affect their eyes, it can affect their neck and their throat, it can cause airway occlusions and other things. So that needs to be taken care of. All right, so that was the right answer for that question. All right, next question or next problem we're going to talk about is ABCs. So obviously our airway, breathing, circulation. So here we have a question: which assessment finder requires immediate intervention in a patient with severe ascites? So I highlighted the highlights are mine. So immediate tells me this is something I have to do right now. And so and I already told y'all it's an ABC question, but even if it wasn't, you know, immediate means acute problem is going on. And even if I didn't know what severe ascites was yet, because I haven't had the liver lecture yet, severe ascites sounds like a bad thing, right? So and we know that that's buildup of fluid in the abdomen from liver failure. So that's what it is. So if you're thinking about your belly being full of fluids in the interstitial spaces, what's immediate? So confusion. So confusion could be considered something immediate, but I need to think about what the other answers are here, and if they make more sense for an immediate thing. I know from what I know about severe ascites, that goes with cirrhosis, which goes with ammonia levels being elevated, which can cause confusion. So maybe that's a normal finding for this patient. This temp 37.2, it's 99 degrees Fahrenheit. I'm not worried about that. That's not a fever. Tachycardia 110, that's an abnormal heart rate, but it's not severely abnormal. Are they going to die from that right now? Probably not. Okay, so I'm going to look for another answer that may be more immediate, which is shallow respirations rate of 32. That tells me that they're in respiratory distress. That is more immediate than any of these other things, because the first thing that will kill you here is going to be if you go into acute respiratory failure, which can happen by the time their body gets worn out to the point that they quit breathing. Ascites pushes up pressure on the diaphragm, which causes lack of lung expansion, which can cause a severe difficulty in getting a good deep breath. And so D is your right answer there. We're thinking ABCs. Okay. Next, we've got actual versus potential problems. Actual problems are almost always going to be the right answer as opposed to what could potentially happen. There are some exceptions, and we bring those out in class when there's a potential problem that may be more important than what's actually going on, such as with pancreatitis. The potential problem of pancreatic necrosis, hemorrhage, and septic shock are very, very important versus vomiting, which is an actual problem. So we're treating both of those problems, but I'm really, really concerned that patient of that potential. But in the majority of questions, actuals are what you're looking at. So with this question, you have a paranoid client having bizarre behaviors, neologisms, and thought insertion. So you have to think back to mental health and what you know about paranoid people, okay? If they're behaving bizarrely, neologisms are those made-up words that they use, and thought insertion, those are all signs that they're deteriorating. So what is our priority for client safety? So if you're thinking about client safety being the priority, assess for medication non-adherence. That could be what's going on with them, but is that acutely the problem right now? Right now, I can look and check that out, but while I'm checking on that, they're out there beating up their roommate. So that's not the first priority. Note escalating behaviors and intervene immediately. That is telling me I'm fixing to do something right now, because I recognize the bizarre behaviors along with these other things, and knowing the diagnosis tell me the patient's at risk for hurting themselves or somebody else. So I like that answer. And we'll look at the other ones. Interpret attempts to communicate. Well, neologisms, we can't communicate with someone that's speaking a language that no one else understands. So while you may try to do that later, that is not your first priority. Chemically restraining the patient when physical altercations occur. Well, it says we want the first priority. So I want to get something done before I reach this point, because you want least interventional to most interventional. If I can do this, then I hopefully won't have to do this. If I go looking at their MARs and then they go out there and beat somebody up or hurt themselves, then I will have to do this. So think about the best thing for the client and the first thing. So 2 would be the right answer there. Okay, next. So think about acute needs versus expected findings or chronic issues. So we're looking for something that's new onset. That's the warning sign for you. That's a red flag. If it's new onset, if it's something that they came in with that they didn't have 2 hours ago and they come to the ER, now they're acutely having chest pain, that's going to be something that you're going to want to pay more attention to. And someone says, my back's been hurting for 6 months. That's chronic, right? Or if someone's labs are off, but we know they have, for instance, pancreatitis, we expect their amylase to be high, don't we? So they may not, that's not as acute as some other things might be. So our practice question is, so with this patient, it is actually a pancreatic patient. So they've got, we're doing admission, so they're just coming into the unit. They have acute pancreatitis. What is the priority finding to report? So here's the thing that's most dangerous, that's most likely to kill this patient right now if I don't recognize it, okay? So history of cholelithiasis, that's gallstones. That's a common finding that causes acute pancreatitis. So while history of that, we can report that, that may end up being what can be fixed to help the acute pancreatitis. That's not going to kill them immediately. Elevated serum amylase, I just mentioned that. We expect that. We can report it, but that's not the priority because our doctor already knows the amylase is going to be high if they have pancreatitis. Decrease in bowel sounds upon auscultation. We expect that in acute pancreatitis. You can report it, but it's also what you expect, and that's going to happen. It's not going to kill them today. Hand spasms present when blood pressure is checked. Think about, why would they have hand spasms when I'm checking their blood pressure? Well, what are labs that are common things that you see with pancreatitis? Well, hypocalcemia or low blood calcium is one of the major lab findings that you find with these patients. And if that happens, that's a sign that their calcium's low. And what does calcium drive? It drives your heart rhythm. And so if the potassium's not where it needs to be, they're at risk for a heart dysrhythmia that could be fatal. So that is going to be your priority problem to report to the healthcare provider. Okay, next. Least invasive. So questions want you to pick up on what you can do that's the least invasive to your patient. So you don't automatically say, oh, they're breathing 22 times a minute, I'm going to intubate them. Without more information, we need to make maybe just put on some oxygen first. So in this question, we have a client with borderline personality disorder. They're at the nursing station reporting that they cut themselves. They have a superficial laceration on their forearm. So superficial tells me it's not very big, it's not very deep. They're probably bleeding some. What's the priority action? So here I know I need to remember what I know about borderline personalities is that they're manipulative, that they like to cut. They typically don't do it very deeply and they like the attention from it, right? So asking her why she cut herself is not a priority here. Sometimes they can't answer that question. They don't know why they cut themselves a lot of times. We may theoretically know, but that's not going to help the situation right now. Ask her to sit in a nearby chair to wait a Band-Aid. Well, that would be least interventional and take care of putting a Band-Aid on her so she's not bleeding all over everything. Place her in a seclusion room. That is a very invasive thing to do. That's a restraint. So you don't want to do that unless she starts acting out to the point of hurting herself or someone else besides a superficial laceration. C is not going to be your right answer, and ignoring the client's never going to be the right answer. Okay, so B is going to be our best answer there. All right, safe practice. So here's another one underneath our T for our top 3 priorities. So and this is a select all. So this is collaborative actions. Collaborative means it's stuff that you're going to do in conjunction with other healthcare providers. What do you anticipate doing that's going to help in providing care to someone with SIADH? So now you have to think back to your endocrine and the fun that was. We know SIADH is syndrome of inappropriate antidiuretic hormone. And we know the opposite one is diabetes insipidus. So if you can just think back to that, you need to know that information. You should have brought that forward from your med surg content from second semester and think, okay, so what are the dangers for that patient? I know this inappropriate ADH means that they are making too much of it. ADH is antidiuretic, which means they're holding on to water. So they're going to have decreased urine output, which causes hypervolemia. So maintaining fluid restrictions of no more than 1,000 milliliters per 24 hours. As you look at SelectAlls, you should think of each answer choice as a separate standalone answer choice. Don't look at them as a group. Look at them as true or false. So true, they're going to be on fluid restrictions because we know they got too much going on already with this problem. Are we going to watch their serum sodium levels? True. If they are hypervolemic, their volume is definitely going to be showing low sodium levels because it's diluted so much. And we know with low sodium, they can have issues with mental status changes, the problems with their brain, etc. So it's a neuro concern there. Are we going to give them desmopressin? Does desmopressin go with this syndrome? So thinking back, desmopressin is for people that have diabetes insipidus, so that's not correct. Assess heart and lungs every 2 hours or more frequently. That would be true. Too much fluid, automatically I'm thinking fluid volume overload. I'm worried about heart failure and or pulmonary edema. So that's something you're checking frequently because that can be life-threatening. Neuro status checks every 12 hours. While we talked about low sodium because neuro status changes, every 12 hours is not often enough. Most of the time, if it says every 12 hours, it's wrong because we want you to do it more often. That would be in every 1 or 2 hours, depending on the severity of your patient's condition. So that's incorrect because this time frame is not appropriate. So there's your answers for that one. And the next one, so this is step 2 of thin. So we had the T's, think of the 3 main power suggestions that each question's given you. And with this one, we're doing help quick. So what's something that says your patient's acutely having a problem, you got to do something right now. So these are your life or death questions usually. So this is a patient, the most concerning safety risk in climate of Addison's disease. So now we got to think back to endocrine, think about Addison's. We learned about Addison's and Cushing. So those were the opposites, right? And they have to do with the adrenal glands and cortisol. And so look at these things and see which seems most important as a safety risk. So weight loss and hyperpigmentation, those are normal findings in Addison's disease. While weight loss may be something I worry about over the long haul, it's not going to kill them this morning, okay? So you're thinking like right now, what's the biggest safety risk? Hyperkalemia and volume depletion. So here I know their potassium is too high, which you do see in Addison's, and they are volume depleted, which means they have hypovolemia. So perfusion's a problem, and their potassium being so high can cause cardiac dysrhythmias, which can be fatal. So I like that answer really well. I'm going to look and see if anything else is more important, but I think I'm going with B here. Elevated BUN and creatinine. So that shows their kidney functions could be off, but they can be off if they're volume depleted. So this right here, while I might be concerned, is not killing them today, most likely. Constipation and muscle weakness. They may have those things as well, but is that going to kill them today? No, it's not. So B is your killer answer. Look for those killer answers that mean if I don't do something, within the next hour, my patient could go into VTAC or VFib and die because of hyperkalemia can be severe in these patients. So that's my big answer there. Okay. Now we're looking at step 3, which is I, and then THI. So identifying risk to safety. So what are some of the safety risks that we're looking at for our patient? So with this client, we've got a heavy alcohol user who is brought into the ED by family members who says the client's had nothing to drink for the past 48 hours. So by that, I'm assuming they mean alcohol. It doesn't say that, but either way, nothing to drink for 48 hours. And we need to report to the emergency department of physician which sign or symptom that is the very most important one, which one's most dangerous, which is our biggest safety concern here for this patient. So hearing and visual impairment, while that's not a good thing, you do see that in people that have been off of alcohol for 48 hours that have been heavy users, because they can have delusions and hallucinations. So while I would be concerned, that's not going to kill them, right? Their blood pressure, 180 over 110, that's really high. And we know with alcohol being a depressant, now they've been off of it for 48 hours, their central nervous system has gone from hypo to hyperactive, which includes their sympathetic nervous system. So now their blood pressure is really high, which can lead to seizures and strokes. So that's why people in alcohol withdrawal can die. So I like that as an answer. I'll look at the other two to make sure they're not more vital. Their mood's bad, 2 out of 10. Well, I expect that, and they're not going to commit suicide right there while we're there with them. So I'm more worried about B still. And then dehydration, while that's also dangerous, they're not going to be very dehydrated if their blood pressure's 180 over 110. Their dehydration's not that severe, or their blood pressure would not be that high. So I'm mostly worried about the blood pressure and alcohol withdrawal. And so they need treatment for the blood pressure and the alcohol withdrawals to prevent seizures and to hopefully prevent a stroke. All right. Now we're looking at nursing process. So this is the last step. So we're almost done in our thin thinking. So this is the in and thin thinking. So nursing process, the scientific method, whatever you want to call it. This is how we make a plan of action for our patients. So with this patient, we see someone that's denying suicidal ideations coming to the emergency department. So they are denying that they're suicidal. Okay, they're here because they have insomnia, irritability, anorexia. So they have a depressed mood. So they're depressed, they're not eating because they have no appetite. They feel irritable, which can also be considered anxious. They're not sleeping well. Which actions would the nurse implement first? Okay, so the patient's reported all these things, which means they're subjective findings. It's what the patient or their family tells you. It's not what you've determined to be true through objective data. So number one is request a psych consult. While this might be something we end up doing, is that the first thing you're going to do? No, it's not. And usually when it says nurse first, it does not mean to tell somebody else to do something, because that's considered passing the buck. Passing the buck is bad, because us and the NCLEX want you to know what you need to do as the nurse. You may need to do a psych consult, but they don't want to hear from you until you have assessed your patient, right? So completing a thorough physical assessment with including lab tests, and maybe we need to make sure we have a toxicology on them, see what else is going on with them. Maybe they have some other medical problem that could cause those symptoms. Patients that are, severely hypoglycemic, if they're diabetic, that can cause all those things to be going on with them. There's other things that can be off that are medical causes. They're not mental health issues that could be causing these things. So we want to get labs and do a thorough assessment. So we know we need to do that. Is that the first thing we need to do? Let's look at the other answers. Place the client on a one-to-one observation. They've already said they're not suicidal. I already know I'm in there with them doing an assessment for admission. So this is not necessary at this point. Request the family to leave the room. Well, I don't consider that my first thing to do. Now, I may ask my patient, do you want your family to leave before I do a complete physical assessment? If they say yes, then obviously I would proceed with ask the family to leave, but there's nothing in the question that suggests that there's a family discord, and I would move forward completing the physical assessment at that point. Now, as I'm starting to do that, I will say, do you want to be alone or not? But, there I'm reading into the question and saying, as an experienced nurse, what I would do. As a new nurse, number two is the most important thing here based on the findings here. And then you would go from there on that question. All right, so that is all I have on those. I'm more than welcome to help people that might need help. And how to interpret using concept mapping. I suggest if you were doing well in your previous classes, keep doing what you were doing that you were successful with before, and just think about these questions are going to be making me apply my knowledge to what a nurse is going to do in the real world. So now we're getting you ready for that next stage. And we recognize that's difficult and that you're tired, and we just want to be here for you to help you be successful. So seek out your mentor and keep giving yourself the confidence to know that you made it this far, so you can make it the rest of the way. Just don't be afraid to ask for help, and have a good rest of the day. Thank you for your attention, and I will post this for you to have access to.